Good evening, good morning, good afternoon, everybody. It is a great pleasure to welcome you all to this new journal club brought to you by the International Academy for Clinical Hematology and broadcasted live from France, Germany, and Italy. I'm Mohamed Moti from the Sorbonne University and Saint Antoine Hospital in Paris, in France. And as usual, I have this great pleasure to moderate this journal club. As usual, we start with the introduction and the paper that was selected by the ICH Scientific Steering Committee is this one published recently in Leukemia, and the title is Allogenic Hematopoietic Cell Transplantation in Advanced Systemic Mastocytosis, a retrospective analysis of the DRST and GREM registries by Dr. Lubeck and colleagues. And it's interesting to note that this paper was published back-to-back in the same issue of Leukemia with another paper summarizing the EBMT recommendations for transplant in this disease. And here is the abstract of this study. This was a retrospective registry-based study which included 71 patients with advanced systemic mastocytosis, aggressive form of the disease, either associated with a hematologic neoplasm, example like AML, mast cell leukemia, and of course, who were transplanted in a single country in Germany over a relatively long period of time, more than 20 years. The median overall survival figures are shown here, and we will be able to comment on them. But one key message was about the improved median overall survival, which was associated with the disease response prior to allogeneic stem cell transplantation, highlighting the importance of disease control in this entity. Also, it was found that the absence of the KIT D816V mutation, but also the presence of a complex karyotype as expected, was a bad prognostic factor. So the patient who did best, irrespective of the subtype, were the patient who were able to receive a TK inhibitor, whether midostaurin or avapritinib. And I think we will discuss all of these parameters with my distinguished faculty. You can see here the characteristic of the patient. As you can appreciate, 71 patients over more than 20 years, relatively young population, median age 58, 57, or 59, 51. And actually, you can appreciate the disease characteristic prior to transplant were very heterogeneous, but we can see lots of bad prognostic factors. Another important feature is that patient received around a median of 2 lines of therapies, up to 5 lines prior to transplant. And we had roughly more than a year between allo and the advanced disease stage. Here are the outcome figures, progression-free survival, but also overall survival. And the blue curve is about the best results achieved in this group. And these are the patient with systemic mastocytosis with without a hematologic neoplasm. And here you can see the importance of response actually prior to transplant, and you can guess the benefit in terms of overall survival for those patients who responded. And one of the key points of discussion in the paper was about the need to deliver an effective treatment in order to achieve disease control. But maybe we will also discuss the issue of maintenance therapy after. And in order to discuss this beautiful and very nice paper in this very rare and important entity, I have the pleasure to have a senior co-author of the paper, namely Dr. Andreas Reiter from Heidelberg in Germany. And as a co-panelist, who are not co-authors of this paper, but who are much involved in this field, Dr. Gandhi Damaj from France and Dr. Francesco Onida from Italy. So thank you all three for being with us today, and thank you for dedicating the time. And Andreas, congratulations for this nice work. And my first question is going to be to you this time, Andreas, and just to give the audience the rationale. Why did you perform actually this study? Why we believe it is important despite a relatively small number, long period of time?
Yeah. So the first thing, good morning, good day, good evening, as you said, Mohammed, and many thanks for having me and for having us invited and that you selected our paper for this really privileged meeting. So, yeah, my name is Andreas Reiter. I am a hematologist from Mannheim in Germany. Can you still hear me? Is all okay?
Yeah, absolutely.
Okay.
You are perfect.
Yeah, my name Andreas Reiter. I'm a hematologist in Mannheim in Germany, and I have to say I'm not a transplanter, but my main interests have been for the last 30 years, particularly myeloproliferative neoplasms in general, and particularly the rare ones. So anything that is not JAK2 V6NF positive, anything that is BCR negative, and I was really deeply engaged into all these fusion genes, you know, like FIP1L1, PTGR4A, and for the last 10, 15 years, also into systemic mastocytosis. And I have to say, one of the main drivers was really the European Competence Network on Systemic Mastocytosis, led by Peter Valent, who installed an excellent network. And so there are several, let me say, centers of excellence for systemic mastocytosis all over Europe. And we have meanwhile also a very strong collaboration with AIM, so with the American Initiative of Systemic Mastocytosis, just really to bring forward this, on one side, rare disease, but on the other side, really also in its incidence and prevalence, underestimated disease. And I really hope that we can discuss that also in our discussion. So, as I said, we are a center of excellence. And as you know, I mean, everything starts usually with treatment. And, you know, with the approval of midostaurin, with the clinical trial and the approval of midostaurin then in 2017, in Europe, I mean, you know, also other people became interested. So, and we looked into the disease. So then we had midostaurin, which is a pan-tyrosine kinase inhibitor with activity against KIT D816V, but then came really very selective inhibitors like avapritinib, or like currently in clinical trials, elenestinib or bezuclastinib. And you know, the KIT D816V mutation has high incidence in mastocytosis. I mean, it's almost like BCR-ABL in CML or JAK2 V6NF in PV, so over 90% of patients. But in the last years, we found out that the disease is very complex on the genetic level. So it's almost like, so the genetic profile is almost like in CMML or in myelofibrosis. So several mutations with prognostic impact. And that means, so in addition to the fact that we can find the KIT D816V mutation not only in the mast cells, but also in the non-mast cell lineages, which it makes to a stem cell disorder. It is also the presence of additional somatic mutations which makes the disease so badly prognostic. So we have about a median survival of this SMAHN or ASM, as you just mentioned, and SMAHN maybe between 3 and 4 years. But for mast cell leukemia, it's only 1 to 2 years. So, and we also have, as you just nicely mentioned, this mastocytosis with associated AML. And the median survival of this disease is less than 1 year. So now we had on one side, we have a very complex disease, morphologically and genetically. We had the tyrosine kinase inhibitors, but like in every other hematologic neoplasm, for cure, you need allogeneic stem cell transplantation. So, and we came across, even as a center, 3, 4, 5 patients, at even one big university center, but probably only 1 transplanted. And it has been for a long time really absolutely our intention to get data collected. And I mean, everybody who is working in this sort of collecting retrospective data, I mean, it has some bad sound retrospective, but this is also very hard work. And if you want to get good data, it is really, I mean, it's it's really, I mean, a lot of work. So, and we already did this sort of analysis at an international level several years ago. So this was also a very nice paper published by Dr. Ustun in the JCO. But now we felt that we should do an update. And we particularly, so as a first step, we wanted really to focus on Germany, because one thing is, so we have ourselves a registry on mastocytosis, and we have the DRST, so which is the national registry for stem cell transplantation. And we just ask these guys, can you help us? Can you help us to identify and to find the patients? And it is a combined study, because also we had patients who had a transplant, but who were not in the registry of the DRST. And therefore it has become to this combination. And finally, to be honest, we were, I mean, extremely surprised that we finally got 71 patients. So we actually thought we may only end up with 30 or 40, but we ended up with 71. And I think now I will stop. So with the analysis, you just showed it. And I think now Gandhi will introduce us a little bit more into pathophysiology, diagnosis, and the phenotype of this disease.
Oh, thank you, Andreas, for these explanations. And again, you should be commended for doing this work, because I know how difficult it could be when it comes to collecting very scarce data in ultra-rare diseases. So indeed, I would like to kindly ask Gandhi, because you've been involved in this disease, Gandhi, in collaboration also with Olivier Hermine here in Paris for many, many years in this disease. So just to highlight to our audience, what are the key features and challenges? And then we'll discuss the treatment and transplant indications and what we should do before, after, in between. But what we as general hematologists need to know about the disease, what kind of awareness and challenges we need to be aware of.
Yeah, thank you, Mohammad. Thank you for the invitation for this meeting. Mastocytosis is at first very interesting disease and very heterogeneous disease, both clinically and phenotypically, as well as at the molecular state. First of all, to speak a little bit about mastocytosis and about all the subtypes of this disease, the median age of the patient, it's between 30 to 40 years for indolent systemic mastocytosis, which is the major part of mastocytosis, and a little bit more, as you see in the introduction of the paper, for advanced mastocytosis, it's between 50 to 60 years, even more. It's the median age of diagnosis. Mastocytosis is heterogeneous clinically because there is two major points to know. There is predominant mast cell activation symptoms, which can detail them if there is a question about that, because there is too many of them. And the second point is the accumulation of abnormal clonal mast cell in various organs. And from those organs, there is the skin, it's the first one, which the major feature is skin lesion, but there's different type of skin lesion. Second one is bone marrow, spleen, gastrointestinal tract, liver, and so on. There is 4 subtypes of mastocytosis. We have the indolent systemic mastocytosis, which is about 70 to 80% of all mastocytosis. There is no organ impairment on that. It's important to know. Just dominated by symptoms of mast cell activation. There is smoldering mast cell, smoldering mastocytosis, which is dominated also. It's a little bit between indolent and aggressive, but it's more classified such indolent mastocytosis. We have here in this type of subtype of mastocytosis some organomegaly, hepatomegaly, splenomegaly, a little bit more infiltration of bone marrow, but there is no impairment of organ, which we call C findings. C findings, we can show them in advanced systemic mastocytosis, which is a point for today's discussion of this paper. In C findings, it's cytopenias, it's liver impairment, it's gastrointestinal tract impairment, and so on. In these subtypes of advanced mastocytosis, there is aggressive systemic mastocytosis alone. There is systemic mastocytosis, which is associated with other clonal hematological disease, and those hematological diseases are mild disease for the majority of them, such myelodysplastic syndrome, chronic CMML, or myeloproliferative neoplasm for the majority of them. And the third aggressive one is mast cell leukemia. Okay, so the first thing to know is there indolent systemic mastocytosis or advanced systemic mastocytosis, and we need to look for C findings, which are organ impairment. This is the clinical feature of the disease. What is the prognosis of the disease? For indolent systemic mastocytosis, we generally accepted that the overall survival of patients with ISM, which we call ISM, indolent systemic mastocytosis, is nearly identical to the whole population. And the treatment here is to control the symptoms of mast cell activation. However, in advanced systemic mastocytosis, the problem is on the other side, is the contrary, the overall survival is impaired. And people, according to the subtypes of mastocytosis, will live. The overall survival is between 6 months, 3 to 6 months for mast cell leukemia, to 4 to 5 years. Historically, before the advance in ATK treatment, we'll speak about that in a few minutes.
So this is really fascinating, Gandhi, because we have clearly 2 big compartments, 2 big entities, the indolent one, and it looks like doesn't impact the life expectancy, although I think clinically it can significantly annoy, I would say, the patient with all the mast cell related symptoms. And then you have the aggressive form, and that brings me to Francesco, to treatment indications and what is the role of transplant there? I mean, we can guess that for the most aggressive ones, but what is the treatment algorithm today, Francesco, especially with the advent of very effective targeted drug like avapritinib and probably others mentioned by Andreas in his initial introduction?
Thank you, Mohammed. Thank you for inviting me to give my contribution in this interesting debate. Yeah, actually, I am mainly a transplanter, so this is my point of view, is the point of view of a transplanter. And my first thought is that when we have to transplant patients with systemic mastocytosis, we should know that these patients are delicate. I know you agree with me, because these patients reminds me, patients with myelofibrosis or with chronic myelomonocytic leukemia. What have in common these diseases? The common is that the common point is that these diseases have involvement of organs, the organs infiltration, which is more than what we usually see in hematologic neoplasms such as acute leukemia. Of course, blood goes everywhere, but this is different. We have involvement of organs, and we have systemic and also organ symptoms related to this involvement. So these are delicate patients, and the patient selection is crucial, because in these patients we have a higher than expected mortality and also relapse, post-transplant relapse. Not than expected, but higher than what we see, for example, for other hematologic neoplasms. So that's why it's really important to clearly select patients with high-risk features, as Gandhi explained. And we have to take into account that the majority of patients with this transplant need are patients with associated hematologic neoplasms. And very often these are maybe acute leukemia, but also MDS, MPN overlap syndrome, such as CMML, for example. And so in this case, we should try to focus our attention on both diseases, not only in the systemic mastocytosis, but also in the associated neoplasms. And we have to be aware that we need to prioritize the treatment on the subtype of disease which is more aggressive and which more affecting prognosis of the patients. That's the point. So I was really interested by the paper published by the German group, because the conclusion are exactly what we expect. I mean, the most important factor is the status of a disease of transplant. A transplant. It's not. I mean, there is age and other factors impacting prognosis, post-transplant outcome, but the most important is how the patients, how is the disease at the time of transplant. So right now, as you said, we have new drugs that were not available for the majority of patients included in this paper, because of course this was a retrospective studies over a very large period of time, more than 20 years. But nowadays we have this KIT targeting inhibitors that works quite good. The first was midostaurin, and now we have this avapritinib. And so we need to learn how to use these drugs in order to optimize the treatment and to try to bridge to transplant the patients in the best situation. I mean, possibly in complete remission. That's the most important things. So we really need to learn how to treat patients, and I think this is individualized treatment that should be carefully evaluated for each single patient according to the disease aggressiveness. And so, of course, the symptoms that has been described by Gandhi. Also, we have to take into account the molecular findings. These are quite new informations, but as you know, in the newer prognostic systems, the molecular findings has been involved. Now we know that there are 3 mutations that have some clinical impact that impact prognosis, and these are mainly the SRSF2 mutation, the SXL1 and the RANX1 mutation. So this is called SAR mutations, and This is important to guide our decision to transplant patients, together with information coming from the associated neoplasm when they have associated neoplasms. But also this information may be important for the post-transplant monitoring. Of course, we don't know that. I mean, we have no clear data because this is a rare disease. But we know that, for example, the clone, mastocytosis clone, may remain somehow with the patient after transplant, because we observe tryptase. Maybe we need up to 1 year before we observe normalization of tryptase after transplant. So
here, Francesco,
yeah.
let me stop you, because I think you're
Sorry.
making my life simple, because I would like to ask Andreas now, because he alluded to the importance of all of these new treatments. And one key message from the paper published by the German colleagues is about the fact that you need really to control the disease before. And I guess for those patients who were transplanted in the series in 2000 or 2001, that wasn't an easy task, except maybe using conventional chemotherapy. But these days, with the targeted agents and TK inhibitors, I guess the recommendation should be to offer these patients such treatment before proceeding to transplant. So Andreas, can you please expand a bit on what you would consider, based on this experience and based on what we know today, what should we do before proceeding to transplant? Because obviously, Francesco convinced us that for the time being, for many patients, a transplant will remain the only curative possibility. But then we would like to optimize the results.
Yeah, I mean, the two previous speakers, so Gandhi and Francesco, already did an excellent job. But I just would like to point out something special about this disease. And this is really this AHN. And please let me explain that a bit in more detail, because this is important. So AHN means, as Francesco and Gandhi both said, it means something like that the pathologist sees a mast cell infiltrate in addition to a disease which looks like CMML. Okay, and this was the first description of that. And because of that, they called it as if there were two diseases. But the problem is, if we go into genetics and if we look into the patients with SM-CMML, in 90% of the patients, the monocytes are also positive for KIT D816V. So it is a fact that both diseases, I mean, they look independent, but they are, in most of the patients, really connected genetically. And also the additional somatic mutations. But we do not know yet exactly. But these additional mutations may be more frequent in monocytes and eosinophils and blasts as they are in the mast cells. So there may already be some heterogeneity in that. So now, and I say that because up to 70 or even 80% of patients with advanced systemic mastocytosis, based on morphology and on genetics, have this AHN. So an AHN can be very heterogeneous. AHN can be very little, let me say, like ET, essential thrombocythemia, JAK2 mutation, very low. But it can also be AML and then you see a bone marrow full of blasts. There are no mast cells at the diagnosis of AML because the blasts are always stronger. But if you look into this bone marrow again, when the patient is in remission, the mast cells come back. So this is very tricky. So the first thing you have to do, you need to be aware of the disease. You need to have really a good hematopathologist to tell you about, the morphology of the disease. And you have to do such a full genetic panel. And you really need to know also something And this is really something I'm still on a fight, even in 2024, let me say, with other hematologists. So for this disease, variant allele frequency or allele burden is extremely important, because, you know, I may have very low KIT, only 1%, and the additional somatic mutation, 40%, which is, you know, then full-blown CMML with a little bit of mast cells. But it can also be the other way around. So it can be 50-50, it can be 10% mast cells, otherwise full of CMML. It can be the other way around. And therefore, you really need to get also a quantitative, you need to get evidence, you know, what is the allele burden? Is it more KIT? Is it more the additional somatic mutations? How does morphology look like? And for example, people may believe that you always need a high tryptase. So the patients with advanced systemic mastocytosis who only have a tryptase of 60, which could be in mast cell leukemia 1000, they are the most dangerous one, because in those patients, the AHN can be really the dominating feature. And now, of course, if you have dominating mast cell disease, like in mast cell leukemia, now with 80% mast cell infiltration, a tryptase of 1000, AHN may be very low. And there, of course, we would definitely go primary treatment with such a KIT inhibitor, you know?
So Andreas, can I interrupt? And maybe because you gave us your point of view about the importance of assessing closely the intimacy, I would say, of the disease. And I would kindly ask Gandhi, maybe, I don't know what is the approach in France and in your center, Gandhi, what is the typical workup that we should offer to a patient suspected with advanced or even mastocytosis, and then, of course, if there is any additional test for the advanced part?
Yeah, it's an important question. What we need to do, the question is on the biological set. It's classical. You need your blood test, your CBCD, serum tryptase. And the question is here, if you have signs cytopenias, even if you don't have cytopenias, we go tomorrow. Yeah, tomorrow with
a bone marrow aspirate.
Bone marrow aspirates and bone marrow biopsies. I know this is a standard of examination for all those patients. We also do cytogenetic analysis, molecular analysis for c-KIT, and we look for additional molecular abnormalities in the bone marrow, looking for the major points that have been cited by Andreas with NGS, myeloid NGS for ISLX1, SR, SF2, and the others, and RUNX1 and the others. Besides of this aggressive, we do the other things like ultrasound for the abdomen and osteodensitometry, looking for bone marrow, for bone osteopenia or bone osteoporosis, which is frequent in these diseases.
So, Francesco,
this is a standard.
So I think it looks like both Andreas and Gandhi are in agreement about the workup and the need for details. But Andreas also alluded to some overlap between these entities, having, for instance, the monocyte being involved or sharing some features with CMML, or I don't know. So you are also an expert in these rare entities, myelofibrosis, CMML, etc. So when we have all of these overlapping features, how do you handle these patients? Is it about saying, well, it is the mastocytosis, which would be the dominant, and my goal is to treat this, or I would take it from a CMML perspective or myelofibrosis? Maybe a totally stupid question I'm asking, but just to clarify this.
No, it's not stupid at all. It's an important question, and actually, it makes me remind one patient I had with chronic myelomonocytic leukemia, which was a proliferative subtype, but you know, the proliferative not requiring cytoreductive treatment. In any case, in these patients, very often think about the CMML patient without mastocytosis. If you have a patient like this, you expect to have hypercellular marrow, very, very hypercellular marrow, like 90% cellularity in a patient like this. This is the rule. Now, when you have two diseases together, then you have to take into account the space which may be available for mastocyte in the marrow may be affected by the hypercellular chronic myelomonocytic leukemia. In this case, for example, the patient was diagnosed with CMML clearly, and the genetic assessment unveiled the presence of the KIT mutations. And then with this information, the pathologist was able to make, the both diagnoses, but he had no C symptoms at that time, and the tryptase were not particularly high. So I followed this patient for several years, but the patient was really reluctant to transplant, and so he was just strictly observing follow-up. But then the disease at a certain point transformed into acute leukemia very, very quickly, and there was nothing we can do. So as far as your question, I think it's very difficult. We have to keep in mind these characteristics, and then trying to focus on, as I said before, on the most important disease, and then follow that.
Wonderful. Thank you very much. So I'm back to you, Andreas. I'm sure you would like to comment on this, but today in 2024, when you have an indication for transplant, and we may wish to discuss the transplant technique, but I was a little bit puzzled seeing in one single country in such a rare disease, 24 different conditioning regimens, so many type of donors. But again, this is about, unfortunately, the heterogeneity we have in transplant practice and the changes we see over time. But what would be the optimal transplant procedure from before transplant, but also post-transplant? Because it looks like, based on what I'm reading, there is a clear emphasis on disease control prior to transplant, but probably some maintenance therapy after transplant, because it doesn't look like that the immune-mediated graft versus mast cell is so potent. Am I correct?
No, absolutely. So I always, every patient should be checked for eligibility for allogeneic stem cell transplantation. I mean, the major issue is that patients are median between 65, 70 years. There's a lot of comorbidity. I mean, finally it ends up like in myelofibrosis, we are talking about it, but only 10, 15% of patients are transplanted. So it's the same in mastocytosis. But in mastocytosis, one bad thing has been that you showed the survival curve of mast cell leukemia, that mast cell leukemia survival is very, very bad. And when you looked into the details of our paper, that in most of these patients, the disease was resistant to whatever we selected in this, let me say, era. I do not know who said it. I think it was Francesco, that of course, most of these patients came from the pre-era of this very effective tyrosine or KIT inhibitors. So number one, every patient should be checked for eligibility. And then I would start every patient with a KIT inhibitor on approval status in Europe with midostaurin. And if the patient is resistant or intolerant, which is possible because of emesis, I would also start with avapritinib. Meanwhile, I would check, for the donor. And you saw that, I mean, like in general, I would not make a big difference between a related donor and an unrelated donor. And then in the meantime, I would already talk with my transplanter, and I would say that I have such a patient. And then we would check out, and now with avapritinib, we presented this data now at EHA in Madrid, and we really have excellent data on avapritinib, whether it is first line or second line. 3 year survival with first-line treatment, over 80%. I mean, remember what I told you before. And this is now something, this makes your question a bit tricky, because now when I have a disease, let me say, with an excellent response on avapritinib, with a very deep response, you know, and the patient is, let me say, at the edge of eligibility, you know, the donor is not perfect. And then, you know, I might slip away a little bit of this recommendation that every patient should be transplanted. And now we are going to check, you know, what are the criteria, you know, who is really, you know, the best possible. And this paper was the first step we wanted to take, you know, to find out what do we need also for successful transplantation. And we were also surprised you showed that obviously, but probably as expected by experts like Francesco, so obviously response prior to transplant is extremely important. So you cannot go, so let's say you have mast cell leukemia, you treat that, the disease is resistant, and you think you can go for transplant. I mean, in general, I would say, forget it. In 9 out of 10 patients, there will be no success. And I could tell you several individual patients. We used all tyrosine kinase inhibitors, intensive chemotherapy like FLAG-IDA, you know, high-dose ARC, whatever, transplant, and it was always the same. Whenever we did the first biopsy, the mast cells were there at the same level as they were, you know, prior to whatever procedure we did. And they are still, and this makes me really very sad, that we still have very resistant mast cell leukemias, and they are really mast cell leukemia with a lot of additional mutations. So, and their survival is 3 to 4 months, usually without anything. Of course, we still go for treatment, for transplant, we try everything. But the response to treatment is very important. And now we also have these very good inhibitors post-transplant. And therefore, and this, I tried to be, that this should be now my last sentence now for this period. So I think that the perfect treatment would be treat the patient with a KIT inhibitor with an embedded allogeneic transplantation in between. But of course, we are a bit, so, you know, with avapritinib, we have problems with thrombocytopenia, and of course, after transplant. But we have now already also started to treat the first patients with avapritinib post-transplant. And it is also the question, should we now treat every patient, let me say 6 months after reconstitution? Also for, you say, you call it preemptive treatment, or should we guide it according to molecular data? I mean, we have very good PCR. And to be honest, if I see a good response prior to transplant, and I see a good transplant outcome, and the patient is still a good candidate, I would definitely always say, treat the patient also after transplant with a drug like avapritinib, except you have a reason for not doing it. You know, whatever, you know, I know that GVHD, you know, a lot of other problems. But in general, I really think the perfect treatment path would be for me the successful prior KIT inhibitor, then a good transplant, and then probably most of the patient also here avapritinib is really the drug of choice for me. So that you should not use midostaurin probably, because if you're not stopped by thrombocytopenia.
Andreas, I think what you are saying sounds like music to my ears, because first, I'm convinced that allogeneic stem cell transplant immune therapy works when you have a low disease burden. Also, what you said about those patients responding nicely and very well to avapritinib, and if you're not in the ideal conditions for transplant, you may question the performance of transplant. That reminds me the initial history of when we use TK inhibitors in CML.
Absolutely.
And maybe we will have in a small group of patients the same story. And obviously, the idea of monitoring and trying to deliver targeted therapy is crucial. So Gandhi, do you share the same approach? I mean, do you have the same enthusiasm? Because it looks like now with the advent of avapritinib, we have in hand very effective, easy to use. Obviously, Andreas highlighted thrombocytopenia, but I would say that's our daily job as hematologists. So we don't want to lose our job. Cytopenia is something we know how to deal with.
Brain bleedings are a little bit, have been a problem. Were a problem.
Okay. So Gandhi, do you share the same enthusiasm, and what are your recommendations for the use of these TK inhibitors like avapritinib?
I agree. First of all, I agree with this, with what has been said by others. Fully agree. And if you look with the second paper with a recommendation from the EBMT, Andreas summarized what are the recommendations from this group of work. Andreas was a co-author for this paper, and I fully agree. We have to allograft patient with lower disease possible, as low as we can, with the newest c-KIT inhibitors. And then after that, when we can, 3 months after, when cytopenia are recovered and the patient is good, we can put them even avapritinib if we can, and midostaurin if that. Especially if patient had high molecular, high risk disease before the transplant, even for systemic mastocytosis or for the other component of the hematologic disease. I fully agree with that, and we should keep, and the most important part also to follow patient for all the cytogenetic abnormalities that have been done before allo, tryptase level, c-KIT, and the other additional mutation at a regular time that we put in this paper 3 months, 6 months. Even we don't have enough data and scientific data on that, but is the expert feeling like what Andreas said before, and Francesco also.
Superb. So Francesco, I mean, all of you were involved in these EBMT guidelines. So today, if you have to refine these guidelines and maybe summarize them for our audience, because we are going to reach the end of this webinar, and based on what we have learned from Andreas' series, based on what we have learned from the previous series from Dr. Ustoon, based on all the accumulated knowledge when it comes to genomics, what would be your approach and the clear, step-by-step approach for transplant in this entity?
Well, as it has been already said by Andreas and also by Gandhi, I think the most important message is to follow an algorithm, which should be a current algorithm using, the current availability of drugs, as we said. So the first thing is to identify the subtype of mastocytosis. So we should clearly classify the patient as having aggressive mastocytosis or mast cell leukemia, for example, and to define if there is an associated hematologic neoplasm. This is crucial. And then the algorithm should be different, because if we don't have hematologic neoplasm, associated hematologic neoplasm, we have isolated aggressive mastocytosis. Of course, we have to count on the KIT inhibitors, and mainly avapritinib, as has been said, is probably the first choice right now, if the patient tolerates it, if there is no problem of thrombocytopenia. And then we might also consider the switching on the other, from midostaurin or vice versa, in order to optimize the treatment and try to follow the patient. Then if there are indications for transplants, then as I said before, we have to try to perform transplant in the best timing is when the disease is at the minimum disease with very good condition of the patients. But if we have hematologic neoplasm associated, as I said before, in that case, the algorithm should be probably different, because if there is a prevalence of symptoms related to the hematologic associated neoplasm, we should follow that, and we should clearly classify the prognosis according to the specific disease-specific scoring, in order to define which is the risk of the patients, because we might have low-risk hematologic associated neoplasm with low-risk mastocytosis or high-risk mastocytosis. So this is the point. I mean, we need to reason and to classify the patients according to this type of algorithm, according to their disease.
Wonderful. Thank you, Francesco. So, Andreas, you will have the final word. So after this publication, what are the next steps? What is your research agenda for this disease?
Well, I think in your previous comment, you really said very nice and very important words. And this is really also about the timing of transplant. We have not yet answered that. So, I mean, you also remember probably very well the time of CML, when prior to, we have said, you need to do the transplant within the first year of diagnosis. But of course, everything has changed with the excellent activity of the ABL1 inhibitors. And meanwhile, we can even safely perform a transplant, let me say, after 20 years of disease with excellent, new transplant procedures. And maybe this is a question we also need to answer for mastocytosis, when I also mention now, for at least for probably a proportion of the patients, this excellent and durable response on the KIT inhibitor, and with also having available probably 2 or 3 or even more new inhibitors. So the question will be, can we keep the patient in the first remission or the first line KIT inhibitor if the remission is really deep and durable, let me say, until he has some first signs of resistance? We then switch to another inhibitor, and we then ask the transplanter. So let me say, same procedure like in CML. Maybe Francesco could also, as a transplanter, comment on that. But I also feel so much remembered on the time with CML, and really with the availability of several active KIT inhibitors. So, I mean, Francesco also said that proper diagnosis, proper monitoring, and it may allow us really to safely perform the transplant also, after several years still in many of the patients. And we
Wonderful.
see that also second line treatment, still there, avapritinib has still excellent activity, second line treatment after failure of others. So this is just one thing. This is a task for the future. And I was so happy to see this fantastic collaboration with transplanters here in Germany. So we already had one in the paper with Ustun, and I think we should just go for another one at the European level again, and then really to be able to stop one of these very important questions on the timing of transplant.
These are fantastic words, Andreas, and I would also add my voice thanking all those colleagues investing and dedicating time in this field of mastocytosis. We know it's already very rare, but also systemic mastocytosis is roughly less than 10% of all mastocytosis. It gives you a sort of an incidence, I think, if I remember well, 1 patient out of 400,000, something like this, or 300,000. And actually, we really need people committed in these ultra-rare diseases, because this is our duty. And I'm very pleased to see that there are also pharma partners who are investing and developing drugs in this field. And so this is like a sort of a global collaboration against mastocytosis. And this is really great news. And I believe while we have already one great drug, as you mentioned, approved like avapritinib, I think a lot more will come. I mean, we remember the story of CML. We started with STI-571, imatinib, and now we have so many TK inhibitors, and it's unbelievable that for a disease like CML, there is still a huge dynamic of research, and there was a New England Journal of Medicine paper a few weeks ago about osimertinib. So thank you all three for your involvement, for sharing your experience, your wisdom, your recommendations, your advice. I hope everybody enjoyed this journal club. Congratulations, Andreas and co-authors, for the work. Thank you, Gandhi and Francesco, for
Thank
your
you.
efforts in the community. And wherever you are, this is the ICH around the globe and across the hematology field. Please stay safe and keep well. Take care.
Thank you. Goodbye.
Thank you. Bye-bye.
Thank you, Muhammad. Thank you. And thank you to Gandhi and Francesco.